Thank you very much. I'm very happy to be here in Vietnam with many old friends and also new friends I'm hoping to meet. So, old and new. It doesn't matter so much. For epilepsy management, we always have the same goals for our patients. Seizure freedom, no side effects of treatment, and a normal life. But we must know that even with old and new medicines, achieving all of these goals may not be possible. We have to be realistic, our patients as well. My friends Ergen Trinker and Tony Marsan said once that the choice of the first anti-seizure medicine is probably the most important decision that a patient with epilepsy will make. I understand what they mean, but I do not agree. The most important decision that a patient will make is to have a doctor who they trust, a doctor who will listen to them and their family, and a doctor who will care not about just seizures and anti-seizure medicine, but the quality of life, support this person. This is far more important than the choice of anti-seizure medicine. Old versus new. What is old? It is relative. Older than me? Yeah, maybe this is old. And so the telephones, these are older than me. But I show you the phone that I use at home. Here it is, my Nokia. My children laugh at me. They say, "Dad, this is so old, you old crazy man." So for epilepsy medicines, older than me is many of our medicines, clobazam, valproate, carbamazepine, etc. So let's look at these old medicines and compare with new medicines. We hope that new medicine may be more effective. Maybe new medicine has less side effects. Maybe new medicine is easier to use. Very importantly, how much does new medicine cost? So let's think about focal epilepsy, old and new. SANAD-1 study in the United Kingdom compared carbamazepine to gabapentin, lamotrigine, topiramate, and oxcarbazepine. Carbamazepine is yellow line. Gabapentin, not so good as carbamazepine. Lamotrigine, maybe not so good. Topiramate, not so good. Oxcarbazepine, similar. So effectiveness, new medicines, no better than carbamazepine. What about side effects? Gabapentin, better, least side effects, but not working. So that's not so good. Lamotrigine, less side effects. So we think, oh, maybe lamotrigine is better. But the drug dose and preparation were not controlled in this study, not using slow-release carbamazepine, which has better tolerability. So not so much difference. Another study in focal epilepsy compared slow-release carbamazepine with levetiracetam. No difference in effectiveness. Levetiracetam, 500 milligram twice a day. Slow-release carbamazepine, 200 milligram per day. Low dose, works for most patients. Do not worry about blood levels, very important. But depression, more in levetiracetam. So, carbamazepine, just as good, but less depression. Okay. What about old people like me? Maybe old people, new medicines are better. Well, randomized double-blind controlled trial in 185 patients older than 65, very old. Lamotrigine, 50 milligram BD versus carbamazepine control release, 200 milligram BD. Comparable effectiveness, but a trend for carbamazepine being more effective, and only slightly better tolerability of lamotrigine. So it's not so much difference. Many people say, oh, carbamazepine do not give to old people, but this study does not support that. What about generalized epilepsy? Generalized epilepsy, SANAD-2 study from UK, from Tony Marsan, valproate versus levetiracetam. Time to 2-year remission, valproate better. Time to seizure recurrence, valproate better. Time to treatment failure, valproate better. No doubt that for generalized epilepsy, valproate much better than levetiracetam in effectiveness. Here is an example from the SANAD-2 study, treatment failure. Levetiracetam, more treatment failure than valproate. Now, we know valproate has problems, okay? We know, and we will hear this in other talks, that high-dose valproate produces birth defects. This is a big problem. This is from a big URAP study from the world. But please note that even low-dose valproate is not so bad, and notice phenobarbital, not so bad either, compared to lamotrigine. A study from Patrick Kwan, Martin Brody, they are looking at, okay, our patients, 1980s, seizure remission, 63%. 2000s, seizure remission, 60%. So in the past 20 years, we are not doing better. Okay, so these new medicines may be not so great. This is a study from Australia. Patients admitted for video monitoring. They do cognitive function testing. They look at age and seizure frequency. These are the main reasons for cognitive slowing. They look at anti-seizure medicines these patients are taking. No medicine, old or new, was associated with cognitive problems. The message here is that side effects of medicines are less important in slowing our brain. Having seizures is worse. So we need to stop seizures, not blame medicine. So, summary, focal epilepsy. Is anything better than carbamazepine? No. Lamotrigine, though, has very good tolerability, less birth defects, and also mood stabilizing. Levetiracetam, no interactions with other drugs, which is very helpful, but we all know 10 or 20% have important behavior problems. Patient may say, I'm feeling good, doctor, but brother, sister says, oh no, he's not the same person. Listen to family. Generalized epilepsy, we now know valproate is the best for generalized onset seizure, but avoid in women, we talk about later in this. Lamotrigine, not so strong, but less effective, but good. Levetiracetam, again, less effective, but plays a role. So old, new, not so different. Now, what about oldest? Phenobarbital. Is it crazy we use phenobarbital? Well, let's have a look. This is a meta-analysis of phenobarb compared to phenytoin, carbamazepine, valproate. Phenobarb just as good in effectiveness. What about now? German study this year, a multi-center study from Germany published in Epilepsy this year, super refractory status epilepticus, seizure termination, comparing general anesthetic, all the new drugs, phenobarbital, the best of all in this recent study. What about children? This study from New Zealand, the NEO-LEV-2 study. Phenobarbital, first-line treatment for neonatal seizures of any cause, complete seizure freedom. Phenobarbital, 80% seizure-free, levetiracetam, 28% seizure-free. Neonatal seizures, phenobarbital, the best. Now, you might say, phenobarbital, very strong, but it make me very sleepy or something, but is not true. Phenobarb compared to carbamazepine and valproate in Taiwan, no significant difference in psychometric testing in new onset epilepsy. Study comparing with phenytoin in India, no differences. In Bangladesh, carbamazepine, no difference. As long as you use low dose, phenobarbital, very strong and safe. And many things have been written, but have been forgotten. And this I found interesting study from 1995. Healthy adults, not epilepsy, take phenobarbital, take valproate, take phenytoin. Compare, not much difference. So if you think phenobarb too old, we throw away, this is not true. So phenobarbital may be allowed to fade in affluent societies, not because of limitations, but because we forget how good it is. This is a meta-analysis I have done of Lennox-Gastaut syndrome, the epileptic drop attack. This is a big problem. Our patients fall, have injury, is very, very sad. This is a combination of randomized controlled studies comparing lamotrigine for drop attack, topiramate, rufinamide, new drug, clobazam, cannabidiol, old drug that is now new, fenfluramine, felbamate. What is the best for stopping epileptic drop attacks? Clobazam. Now, I must admit there is another new drug that we must also include. You notice felbamate number 2. Felbamate we stopped using because of bone marrow problems and liver problems. But now there is a new medicine, cenobamate, very expensive, that is looking very good. So cenobamate is a new drug we will be hearing more about. Now, what about side effects? Harry Manardi said, the greatest side effect of anti-seizure medicines is their cost. Financial toxicity, very bad. All the new generation drugs, original or generic, are unaffordable in most Asian low middle income countries. And we know this, of course, because of my friends in the audience who've done very special study published in Epilepsy this year that show the number of days wages for the lowest paid government worker for these medicines is like about a week or 2 weeks of wages. This is compared to Europe, where it's like 2 hours of normal wage. So, treatment choices. Is there one drug that is the best? Number one, no. No medicine is best. We need individual approach. We listen to our patients and their family. We tailor to individual symptoms and regularly reassess. Are your seizures happening? Are you feeling well? Are you sleeping okay? We determine the drug by the seizure type and epilepsy syndrome the individual patient, but also very important, can the patient afford the medicine? What is the cost of the medicine to the patient? Old versus new is meaningless. New becomes old. Cannabidiol, cannabis, is very, very old, thousands of years. Now it's new. New seizure medicines do increase our options so we can use different medicines for our different patients. Newer does not mean better. Newer medicines are not more effective than old, and adverse effects are not so different. We choose depending on the individual patient. Most importantly, in our region, cost and availability of medicine is a big problem. But if you think, I only have phenobarbital, I'm poisoning my patients, this is not true. Phenobarbital is a very good drug. The old drugs are very good drugs. And so, I have my old phone, okay? I use this old phone. I also have, and Minan and others teach me, I have new phone too. Sometimes I use new phone, mainly to take photograph. Sometimes I use my old phone. Both are very powerful. And I think of medicines like the movies. What is better, the old movies or the new movies? Okay? Chris Hemsworth, Marlon Brando, Audrey Hepburn, Scarlett Johansson, Audrey Hepburn. Come,